Hello, everybody. Reed here. How's it going? Today, we're going to have a very interesting conversation. It's going to be about Abilify Maintena, a long-acting injection. First, hey, Shariah, how you doing? Did you want me to put you on the screen, or you just want to talk there? Hey, Shariah, how you doing? Can you hear me? Oh, I'm sorry. Can you hear me?
Yeah, I'm here.
How you doing? Okay, I have you on audio. Okay.
Okay.
All right. So I'm making some coffee. Let me get my some tea. Let me get my tea first.
Okay.
Okay. Now it's Shariah, correct?
Yeah, it's Tria.
Shariah. Okay. Gotta get the glasses on. How are you doing?
I'm good. How are you?
Hey, hey. While you're here, it'd be interesting to get your input on some of the lectures, or if I need to change anything. Any input? Uh,
No, I've watched your lectures, even like the ones you do on YouTube, and it's it is really informative, and I like that it's on YouTube, so I can just like go back and watch them like when I need to. So yeah, I like the format.
oh, that's great. Okay,
Yeah.
thanks.
Yeah.
I'm glad it's helpful. And believe me,
Yeah.
going through this stuff, man, I mean, it refreshes me up on everything. I mean, it
hmm
seems like everything is accessible now because you
Yeah.
basically study every day, right?
Yeah. Yeah. Even like things you discuss in the rounds, like when I'm doing my practice questions, like it kind of comes up, like how we have to do the tryout before we can do like the shot for
Hmm.
like the Haldol shot. You have to do the oral, so that was kind of like actually came up in a question. I was like, oh, I know this. We hear it every day, so
Mm.
yeah, things like that do come up too.
The benefit about my rotation is you see a lot of people,
Mhm.
and then you get the chance to see the pattern, right?
Yeah.
And I think that's the majority of it.
Yeah.
The patterns, everything else makes sense, right?
Yeah, especially because like the inpatient stuff is like you don't see it as much, like compared to like outpatient. Like you might see like depression and stuff. You might see more regularly, even in primary care. So like, but the inpatient, like the disorders, it's like a good way to see it all.
Mm. Great. I got an idea for you. I'm so glad you're here. I get a chance to test out my ideas.
Okay.
Um, I've been doing this for like 6 years.
hmm
Like, and this is 7 days a week.
Yeah.
And all of my all of this is recorded on Zoom.
hmm
So my producing team is going to basically de-identify everything, make it
I
HIPAA
would make
compliant,
it like lectures.
and then basically do for a whole 30 days,
Oh, okay.
right? And
hmm
so we can run it as a simulation. I
Yeah, like the
people stream
cases.
it as if it's real, right?
Oh, okay.
So think about this. So sorry, chocolate
You're okay.
good. Chocolate good. Um, so I wanted to build a type of rotation that you can take from home and pay only $500.
Okay.
So imagine me streaming like this in real life. Okay, so I'm streaming
hmm
like this. And so let's say you're my assistant, right?
hmm
Now, let's say we're going to start the class in 20 minutes,
Okay.
right? So all the people are going to be logging into the platform, right?
hmm
Logging in like they're doing right now, like you logging here. and then I'm going to start basically I'm going to start this, you know, and then whatever here that's going to be playing, right? But it's going to be streaming, right? So the rounds are going to be streamed here
Oh.
while you and I are in real life, right?
Hmm.
And then after the rounds, then I can see patients online, or I can ask questions right there for the students.
Yeah.
What do you think? You see what I'm saying? So just like if you're my assistant, and then if you want to sign up for my rotation in psychiatry, it's just $500, right? So you
Yeah.
sign up, and basically you get the link, and you appear like on the stage like you. Okay, um, on the stage like I didn't know if you wanted me to show you. Sorry. I'm sorry. I didn't know you wanted me to show you. Sorry about that. I'm new at this, okay? Um, but you can have more people who come in and watch just like you, but then they can just watch the stream of the rounds. Oop, hold on. Ooh, hold on a second. Okay, I'm sorry. Repeat that again.
I said, yeah, it's really good, especially if there's kind of like it's if it's streamed and then you could watch the recording later. So like watching the recording, I think is really helpful because you can like kind of go back, take
Yeah,
notes, or if you miss something. So it's like nice to have that library, like catalog.
yeah. But see, okay, so but my rounds, so my program is going to be in real life streaming.
Yeah.
So I would be here around my place, just available, right? And when it's time for school to start, they'll come in, I'll start the simulation. They'll go through the stuff for time. If they had any questions, they can just hit me up with any questions.
Okay. Would there be like a video library, like how you have your other lectures to go back to watch it? Like you can watch the
Well,
stream.
see, we're going to identify each day of rounds,
Mm-hmm.
and then attach metadata to the subject so it links to my YouTube videos,
Oh, okay. Yeah. That makes
right?
sense because
So
as
when
long
we
as
talk,
there's like something to go back to, that would help. Because
Mhm.
the discussion in person does help a lot, like having the rounds and like watching and listening, like that's all good. And then because I know some people like it's kind of like after the fact, like, oh, let me go back
see,
to review.
see, the thing is that when they see me rounding, it's going to be streaming.
Hmm.
So it's going to appear to be in real life. I mean, in real time.
Yeah.
Or they can stop it
Hmm.
and click on the link
Yeah.
and get the video of me explaining,
Yeah.
and then restart the rounds.
Hmm.
Right? And then afterwards, the simulation, they just come back to this main group, and we finish talking from there like that. I
Yeah.
would think that would be a cost-effective, very good way to get students in the program.
Yeah, especially because it is like you said, like pattern recognition. So it's like seeing the cases, but then also like getting into the details of like what differentiates kind of like the small details. Like that's how you can like start to learn.
Hmm. You think it's a good idea?
Yeah, I think so.
I think it's revolutionary.
Yeah, it is.
Look how many medical students. I mean, look how medical students used to take a rotation needs to take a rotation in psychiatry, and you can do this from home for $500.
Yeah.
Now, how did you? Now, like, what school are you from again?
I'm from Xavier.
And where is that at?
It's in Aruba, actually.
Okay, so you have to fly all the way over here to take this rotation.
No. So like after we do our basic science, like on the island, we do our rotations in the States. And so like if we're in New York or Chicago, like wherever we get placed, we go.
But you have to bear the expense of doing all the rotations.
Well, we pay tuition and then our school places us. So we don't pay directly. I guess. The school arranges it.
And they pay for your housing and stuff like that?
No, we pay for that.
So, but you still have to pay for yourself, right?
Yeah, we do have to pay. We just don't pay the hospital or anything directly. Like we pay the school and the school pays.
So I'm saying, but to be able to take a psychiatry rotation at home for just $500 is really inexpensive, right?
Oh
As
yeah,
opposed
that
to
is
having
very
to
cost
do-
effective.
and how much would it cost? Does cost on average now? Let's say if you had to come to Chicago, get a place to stay, and then do it for a month,
Yeah, I mean like rent would be like maybe like a I don't know 1 to 2 thousand, right? Like it'd be
yeah,
expensive plus cost of living,
and
even
then
groceries.
travel.
Yeah, travel. So it'd be like at least a couple thousand, like three
So,
ish
but
maybe.
I think to offer this type of rotation, I think everybody was signed up because just for $500, right?
Yeah, it is really convenient. And yeah, it is like a lot easier to do it like this.
Yeah, it'd be interesting. Well, thank you so
Yeah.
much.
Yeah, no problem.
Thanks for your input.
Yeah, of course.
So let's see. Today, um, this discussion is on Abilify Maintena. Let me see here. Let me go through. Let me just first, Abilify is a atypical antipsychotic. So let me have an AI explain and see the mechanism of Abilify. It has a unique, like most of the antipsychotics, they block the dopamine receptors, but this does something else differently. You know, so let me say, Abilify Aripiprazole is an atypical antipsychotic known as a dopamine serotonin system stabilizer. So here we're introducing the concept of both dopamine and serotonin. Remember, with the typical antipsychotics, they only bound like D2 strongly or D1 and things like that, but they didn't bind in other receptors like norepinephrine and serotonins. So the typical antipsychotics are used very effectively for psychoticism, but they are not really effectively used for mood disorders. But the atypical antipsychotics, because they target serotonin and norepinephrine and other receptors, they're also used as mood stabilizers also. So here's the dopamine from the antipsychotic component and the mood stabilizing component, because it also targets serotonin. Its unique mechanisms, that's what I wanted to point out, involves balancing dopamine and serotonin levels in the brain by acting as a partial agonist at certain receptors. Remember, the antipsychotics are supposed to block the dopamine receptors, and now they're saying it serves as a partial agonist at certain receptors, right? This adaptive or stabilizing effect is distinct from traditional antipsychotics that simply block dopamine receptors. Yeah. Um, so so you can see that these atypical ones, they're really important for stabilizing mood. You know, so I use them often when I can't figure out what the diagnosis. I don't want to say it like that. If I'm unsure what the diagnosis is, if it's a mood disorder, instead of putting them on an antidepressant, I'll go ahead and put them on something like Abilify, because the antidepressant, there is some evidence. There's we used to believe that antidepressants precipitated manic episodes, but I think there is some evidence that's coming that's questioning that. So I don't want to say that antidepressants precipitate manic episode, but that was the traditional understanding. So if I'm not sure if the person is really bipolar, but just presenting in the depressed phase of the bipolar disorder, then I'll just use Abilify because I know it can help with the mood stabilizing effects there. The dopamine system stabilization. Abilify's most significant action is its function as a partial agonist at the D2 receptor, the primary target for antipsychotics. Remember, this D2 receptor is very important. That's the target of those typical antipsychotics like Haldol, Prolixin, and Thorazine, and it's a potent blocker. So it gets into the receptor sites and it blocks the dopamine molecules from getting access to the receptor, so you can't trigger the receptor. And Abilify is activating. The Abilify is activating the receptor, right? The primary target, okay. This contrasts with older antipsychotics, which act as full D2 receptor agonists or blockades. Yeah, it seems like I'm right ahead of the AI.
Yeah, yeah. You're explaining it before they do.
Yeah, yeah. In areas with increased dopamine activities, okay, in areas with low dopamine activities. This is interesting. Okay, for conditions like schizophrenia that involve excessive dopamine in certain areas of the brain, Abilify act as a functional antagonist, meaning blocks it. It competes with natural dopamine for the D2 receptors, but because it only partially activates them, it effectively lowers the overall dopamine signaling. Wow, you got it?
Yeah,
So,
that makes sense.
so Abilify competes with dopamine for the dopamine receptor. And when it does, it just activates it just a little bit,
Yeah.
but it prevents the dopamine from binding, and the dopamine will activate it a whole lot more, right?
Yeah.
This is very interesting. When these people who think through this stuff have to be amazing people. Can you imagine?
Yeah, like how it, because it works for, I know, because like the atypical work for both like positive and negative symptoms,
Hmm.
right? So it's like, so this is like in the positive, like the
Well,
mesolimbic pathway, right?
yeah, see, remember, I did a lecture on a podcast on the negative symptoms, and I went through the literature, and basically nothing really works.
Yeah.
It's just time. And then they were saying that maybe atypical antipsychotics like Seroquel at low doses and things like that, but they're saying nothing really works. So with these, we focus on positive symptoms and just hope that the negative symptoms improves. You know,
Yeah.
but
But
because
then,
it causes a functional blockade at the D2 receptors, it'll still decrease the hyperactivity in the mesocortical pathway. It only gets stimulated 1% as opposed to 100%.
yeah.
Okay. This helps reduce positive symptoms such as hallucinations and delusions. Right. In areas of low dopamine activity, in other brain regions where dopamine levels may be too low, hypodopaminergic, Abilify partial agonist activities provides a mild activating boost to dopamine signaling. It is believed to improve negative. Oh, that's the mechanism for negative symptoms like flat affect, motivation, and potentially cognitive function. Oh, okay. So it's the. I'm just now understanding that. So it's the. So apparently in this schizophrenic state, you have areas of dopamine hypoactivities intermixed with areas of dopamine hyperactivity. So the Abilify will increase the. It's a malagonist, and so it will still at least increase the production of dopamine in those hypodopamine areas a little. And I guess that's
Yeah. Like
that's
stimulating the receptors.
this is great. Okay, serotonin, and I think it only gets better. It only gets better when you think about the serotonin receptor. I'm sort of like getting excited to see and hear about the serotonin, what it does with serotonin. Um, in addition to effects on dopamine, Abilify also modifies serotonin activities. 5-1-HT receptors and the 5-1-HT2A receptors, right? Abilify acts as a partial agonist at these receptors. This action is thought to contribute to mood stabilizing effects, especially when used to augment antidepressants. Okay. At the 5H2 receptors. Okay, now remember the um, remember the SSRIs, they're called selective serotonin reuptake inhibitors. They
Yeah.
work by turning off the serotonin reuptake pump on the presynaptic neuron, right? So
Yeah. So there's more like serotonin in the cleft to keep activating.
exactly. So that plume of serotonin in the synaptic cleft builds up, and then now you get more binding of serotonin to the serotonergic receptors. and that is the signal from the presynaptic cell to the postsynaptic cell, right?
Yeah.
Great. Now look at how they're proposed. Now that's the mechanism of all SSRIs.
Mm-hmm.
Let's look at now. They're describing the mechanism of an atypical antipsychotic that also binds the serotonin receptor. But look,
Yeah.
it actually binds the serotonin receptor and causes the postsynaptic cell to produce more serotonin, even though the synaptic cleft may be deplete of serotonin.
Yeah. So it acts like
You got
serotonin.
my saying? So
Yeah.
if it's depleted serotonin, then you want to go ahead first, turn the pump off, please. Just turn the pump off. Turn the reuptake pump off. Stop pulling the stuff back in. SSRI, right? And then so you put them on the SSRI, and then the starting dose 2 weeks later. Oh, I'm feeling better, but I have to increase it a month later, and they're I'm not feeling better. You get the maximum dose of that SSRI, and they're still feeling depressed. I mean, what are you going to do? Then that means that this medication may not be whatever is those those reuptake receptors are on the presynaptic cell. Maybe they're genetically a type where they don't respond as much. I don't know, but we're not getting the reuptake inhibition, because if the depression is not lifting, that means that plume of neurotransmitter is not building up in the intracellular cleft. Does that make sense? So you're in that situation. So the only logical thing to do is to start hitting the postsynaptic receptors yourself and turning them on yourself. You got me? So that's why you're going to give the Abilify to hit those postsynaptic receptors, because you're assuming, hey, there may be not enough dopamine. There's not enough serotonin in this intracellular space. And so how am I going to get this serotonergic network upward? First, turn the pumps off, right? And then second, start turning on receptors yourself, right? Does that make sense in terms of Abilify? And so therefore you'll get an increase in the transmission of serotonin across the serotonergic network, and therefore you get a lifting of the depression. Got me? Make sense? Okay, next, 5-HT2 receptor. At these serotonin receptors, Abilify act as an antagonist, blocking their activity. This effect is common among atypical antipsychotics and can help reduce EPS symptoms such as bipolar. Yeah. So the EPS symptoms may come in from hitting too much serotonin and stuff like that. So this serves as an antagonist, okay? The overall adaptive effect. The combination of these actions is what gives Abilify its dopamine serotonin system stabilizing label. Instead of a simple on-off switch, the drug modulates neurotransmissions based on existing levels of neurotransmitters in the different parts of the brain. This is amazing. The result is more targeted effect with lower risk of certain side effects compared to older side effects. Yeah, because if they're having symptoms of hypodopaminergic activity within certain areas, like if they're catatonic, withdrawn, hypoactive, right? Then that suggests that they're hypodopaminergic. And so I would say that, hey, instead of putting them on a very potent D2 blocker that's going to block dopamine even further, right? That's why the atypicals. So I say at the molecular level, and what level you're getting this really good. What level are you at?
My year. I'm going, I guess, into my 4th year. Yeah.
Okay, you're grasping this, I mean, really well.
Oh, thank you, Dr. Reed.
Even at the molecular level, you're grasping what my descriptions at the molecular level too. Are you going to go into psychiatry?
I'm not sure about psychiatry. I like, because I used to work in cardiology, so it's kind of something I've always loved.
I used to advise students to not to go into an area of medicine where you have to touch somebody.
I know you said this the other day. Just like don't touch patients. It's like okay.
Because you always
Yeah.
out of your bed. You're gonna have to have a family life, right?
Yeah.
And medicine's gonna be always there. You have to be able to turn it off. But now I think that may be bad advice because I think AI is going to run psychiatry.
I know you said you're developing your program with all of your data that you have. So,
Yeah. Yeah, part of the lecture series is to teach the AI all the different concepts.
hmm
So the transcripts from all of these lessons are going to be uploaded into my AI. And so when it needs to ask questions, it can answer questions. Like it can look at the stuff and then answer questions.
yeah. Yeah, because I remember we talked about like how like some people try to like manipulate like when we do rounds and stuff and they try to manipulate like you and like bring you into their reality and stuff, and then we talked about how like the AI would be able to like kind of like catch on to that and stuff, and yeah.
See, the AI is going to be the only entity able to treat the narc.
Yeah.
And like, otherwise, you're going to get in that world. You know what I'm saying?
hmm
They have that magnetism to draw you in, and you got the only thing
yeah.
you can do is no contact and run away. So the
hmm
narc, so the AI is going to take care of all. I mean, it's just and right now, the the name of the game is data.
yeah. Yeah, it is all about the data and teaching the AI.
Where you gonna get your data?
hmm
Huh? I'm serious though. Where you gonna get your data? What's your plan?
yeah.
No, I'm asking you a question. Where are you going to get
Oh,
your data?
my data. Oh, I
Yeah,
don't know.
that's the plan. I mean, that's you. This the first time you thought about this.
Yeah, I haven't thought about it.
Okay, now would you see me collecting data
hmm
all the time? This is what this producing data,
Yeah.
right? Um, it's gonna. I mean, change is about to come really quick. I mean, it's coming very quick.
Yeah, I've also like I even heard about in like radiology right now. They're starting to use AI to like read the images and stuff because like radiology is all image based and AI that's like where it excels the most, right? Like image and pattern recognition. So like they've already started working on it for
Yeah,
radiology.
I mean, just image recognition. I mean, that's already it's already established. You know,
Yeah.
I mean, that's like modular now. You know,
Mm-hmm.
but what's interesting is you know, when we started thinking about building the AI and things, we're trying to say, how do we help it understand abstract concepts,
Yeah.
right? And so that's why you see me collecting a lot of data like scales,
Mm-hmm.
right? Because let's say if I do the BPRS, the brief psychotic rating scale on all of my patients, you talk
Mm-hmm.
about hundreds of thousands of BPRS scores. That's my
Yeah.
sample size.
Yeah.
You know, so we've been able to figure out ways to sort of normalize data so that the AI can ask questions to you, plot you that your data along everybody else's, and look at the differences and things like that, and then try to come up with some reasoning based upon those differences. You know, and then it's going to be able to just look at all of my cases and sort of figure out what's the best pathway to take.
Mm-hmm.
You know, and so the AI, and so the thing is that the AI is only going to be as good, as useful as the data you put,
Yeah.
right? And so that means that Elon, Microsoft, and everything, they can't make an AI for medicine,
Yeah. Have
right?
you heard of open evidence?
No.
So that's the AI for like a lot of people use. So that one is like it's clinical based. So all like when you ask questions and everything, all
Mhm.
the information comes from like published articles like JAMA or New England Journal of Medicine, and so that's where it gets all the information from. and so it's all from like published like data. So when you ask questions into this AI, it's already pulling up like medical information.
That makes sense. So basically, it's sourcing the medical literature and those
Yeah,
resources, and then it's aggregating them and then presenting it back to you.
yeah,
This is amazing. This
yeah,
is interesting, amazing. Um,
yeah. This is the AI that I've heard a lot about, because it's giving you like the most up to date research. Like, you know how like sometimes if you're looking on like, up to date, or you try to search PubMed, like this is kind of the next level of it.
mm. Oh, thank you so. Listen, I appreciate you coming today and showing me about this. Wow,
Yeah,
I appreciate that.
yeah. So you should like compare it to like the Google one and see, because it'll give you like the clinical trials. So if
Oh
there's
my
any new
God,
data,
yeah. Okay, yeah. So let me.
yeah,
Can I put like explain?
yeah.
Absolutely. It's maintaining. Yeah, I spelled it wrong.
Yeah, I think the also like, yeah, the brand name and stuff. But yeah,
Oh, this is excellent, man. I wonder if they have a um API for this. Man, this is great. Yeah. So Abilify Maintain is not okay. Okay. The mechanism of action of Abilify Maintain, aripiprazole, is not fully elucidated, but its efficacy in schizophrenia is believed to result from a combination of partial agonist activity at the D2 receptor and serotonergic in the 5-HT1A receptor and antagonistic activity at the 5-HT2A receptor. Aripiprazole exhibit high affinity for the D2 and D3 receptors, serotonin HT1A, HT2A receptor, and moderate affinity for other receptors, including D4, serotonin, these alpha adrenergic histamine and histamine receptors. It has negligible affinity for the cholinergic, muscarinic cholinergic side effects. So it doesn't have any muscarinic cholinergic side effects.
hmm,
Okay, that makes sense. So
yeah,
the partial activity at D2 and the serotonin, and then the antagonist activity is the
hmm,
5-HT2. Okay, the
yeah,
unique receptor profile underlies aripiprazole's clinical effect, including antipsychotic efficacy and lower risk of EPS symptoms compared to full 2D antagonists. Yeah, that's so. If you place someone like on the antipsychotics, they start getting stiff and things like
yeah,
that, start having difficulty moving, start
hmm,
having dry mouth from antihistamine, anticholinergic side effects on that's because it is full D2 blockade. And so you may want to switch to Abilify to avoid those potent side effects from coming from aggressively hitting the D2 receptor. The partial agonism at the D2 receptor allows for stabilization of dopamine neurotransmission, which is thought to contribute to its favorable side effects because it's increasing dopaminergic activities in the area that's hypodopaminergic.
hmm,
Recommended dosage of Abilify Maintena is 400 milligrams administered IM a month, with a reduction to 300 for patients experiencing adverse side effects. Okay.
yeah,
Uh, okay. So this went through the um, updates on the mechanism of aripiprazole, translation insights into strategy beyond dopamine. Okay, antipsychotic strategies behind dopamine. A, a drug that displays partial and agonism and functional selectivity. That's interesting. A novel antipsychotic drug with unique, robust psychopharmacology. Let me see this one. This is so helpful. Yeah, PubMeds. Okay.
hmm. So yeah, that's where all the information comes from. So it comes from like the NIH library essentially.
Mm.
And you can even like compare like clinical trials. Like if you ask like what is the efficacy or like the reduction. Like I think if you click, there's a question. It says like, would you like me to summarize the clinical trial and things like that.
Like here, where's that question at?
It's at the last sentence.
Describe the interaction.
Yeah. Or
Okay.
like if you, yeah. So
Okay.
like they always have like really good data.
Okay. Key drug interactions for the efficacy. Strong CYP 234. I'm gonna go through these a little bit later. Let me later. Let me explain. I wanted to learn more about the delivery system of the long acting. Okay, the maintenance dose delivery system for aripiprazole in the long-acting injection formulation known as Abilify Maintena. So Abilify Maintena is the monthly injection, consists of once monthly intramuscular injection administered in either the deltoid, the buttocks, or the gluteal, the side muscle, in healthcare professionals. The formulation contains low solubility aripiprazole particles resulting in slow and prolonged absorption into systemic circulation. Low particles, so they dissolve it in particles, resulting in slow and prolonged absorption into systemic circulation. After injection, plasma concentrations gradually rise, reaching maximum levels at median 4 to 7 days, depending on the injection site. Steady state concentrations are typically achieved by the fourth monthly dose. The recommended maintenance dose of 400 milligrams monthly is reduced to 300 for patients experiencing adverse reactions. What do you mean low solubility? Or let me see.
I think it's like because it's like the fluid it's like suspended in. So like that's the solubility of it. So it stays like around the injection site and then slowly released. Is that
See,
what it's saying?
you see, that's I wanted them to describe the mechanism. They just described an event, but not the technology. You see what I'm saying? So, like with Haldol, they create a ester bond. See, with Haldol is uh, waterphilic, aqueous, right?
Yeah.
Now, in order to make it a decanoate, they create an ester bond to it. A decanoate is an ester bond, and that makes it lipid soluble. So
Yeah.
it's put in the solution, and then it's injected in the muscle, and then by your immune system, it hydrolyzes, it snaps the ester
Yeah.
bond, and then it releases the haldol into the aqueous, the water portion of the body, so it gains access to the bloodstream that way. So I can see how you can create the haldol decanoate and the prolixin decanoate through creating ester bonds. Now, the Invega Sustainer, I believe, is packed in lobules, something like that. It's
Yeah.
and then the lobules are chewed down, and then it's released or something like that. But I was looking for the mechanism of the maintainer.
Yeah, maybe if you ask about like the pharmacokinetics or dynamics, it might explain like how it's able to release it. I'm not sure.
Well, I'll check it a little bit later. I'm going overboard here. It's like 40 minutes now.
It's okay.
No, hey, it's a great conversation. Hey, and thank you for teaching about this because I think I can integrate. This will be more appropriate for the medical students and things like that. Um, um, okay. Well, thank you so much. I
Yeah, no
appreciate it.
problem. Bye, Dr. Reed. Thank you.
Take care, buddy. Thanks, guys. That ends my presentation on Abilify Maintena. I hope it was very helpful for you. And Abilify is a very effective medication. Take care, guys. Read out. Ciao.